The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, everybody. It's Tuesday morning, and we are gathered here for the next episode of TMD Demystified. I am Tony Urbanek. Today, I am going to discuss the proper role for orthodontists treating TMD. Orthodontists definitely have a role to satisfy in treating temporomandibular joint disorder. Again, to remind you, it is one disorder. It is not multiple disorders, but I'm not going to go deeply into that again. I want to focus on the role of orthodontists, though, because in my 50-year career as a reconstructive oral and maxillofacial surgeon, I have had literally hundreds of patients come in for consultations who have told me that they have been either told or treated by an orthodontist that getting their teeth straight would satisfy and treat their temporomandibular joint disorder. And some of them did not go through treatment, and some of those did go through treatment, but I can easily say that there were hundreds in that 50-year career who said they were seen by an orthodontist who claimed that they needed to get their teeth straightened so that their TMD symptoms would go away. TMD symptoms meaning frequent and or recurring headache, earache, jaw pain, neck pain, tinnitus, ringing in the ears, subjective hearing loss, fullness in the ear, dizziness, vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. Those are the well-known, well-established symptoms associated with temporomandibular joint disorder. But what I found was that the patients who did go through treatment were sitting in my office with some cases all of those symptoms, which had straight teeth, but did not fix the problem. And I want to kind of discuss that for the benefit of the orthodontist and the patients, but mostly for the benefit of the orthodontist who may tune in or listen to this podcast or episode later on, so that you have a better idea of your place and your role in treating this problem, which is a very important role. But first, let me explain what the theory is behind the fact that orthodontists make the claim that getting straight teeth will make the symptoms go away. And it goes something like this. Malocclusions encourage bruxism. So you have to define what is a malocclusion. Well, to an orthodontist, primarily a malocclusion is where the teeth do not fit together well, and that you may have high spots. You may have teeth out of position. You may have teeth that hit first, and the patient has a lot of attention on a tooth that is out of position, and they keep bumping into it, which puts their attention on it, which can admittedly stimulate bruxism. But what the orthodontist is treating is what we call centric occlusion. That is, this is how teeth fit together, whether it's good or bad, whether they're all out of position or not. Centric occlusion is where people have a bite that meets together that they chew their food with. And if you're a dentist, you know the basics on that. They're class 1, class 2, class 3 bites and variation of class 2. But the point is, the orthodontist, when they see teeth not fitting together, they feel that that will stimulate bruxism, which actually can stimulate bruxism in certain cases. And then bruxism is one of the known causes of joint damage, which is a true statement, and therefore cause TMD, and that straight teeth discourage bruxism by removing all the interferences of the bite. But what you're removing the interferences on is their centric occlusion. And as the dentists know out there, for sure, I know you were taught this in every dental school in the country, and the patients are not aware of this, but everyone has two bites. You have the bite where the teeth meet together, where your morning chewing, evening chewing bite, where your teeth have learned to mesh together with or without the help of an orthodontist, good or bad, that you use to chew with. And then there is a second bite that 100% of humanity, 100% of the population has a second bite. And that bite is where the ball of the condylar head fits in the glenoid fossa. The ball fits in the socket of the jaw joint properly in its most comfortable position. We call that rest position, is one of the names for it. It's also called centric relation. So you have centric occlusion, which is bite one, where you have learned, with or without the help of an orthodontist, to get your teeth to fit together, and bite two, where the ball fits in the socket. And orthodontists primarily treat bite one. And they look at bite one and how they can manipulate the teeth around so that they fit together exactly the way they should. And that's a great service. But the question is, does that actually fix TMD? And the answer is no. It doesn't. And the reason it doesn't is because of the fact that there is a difference between bite one and bite two, where the ball fits in the socket. And if that difference is significantly large, greater than 2 or 3 millimeters, that is the difference that overloads the joint. So there are three causes that damage the temporomandibular joint. Bruxism is number one, and by limiting bruxism, you can have some effect, but minor effect, on limiting bruxism. It's not a great effect, but having the teeth fit together is an advantage, but it does not treat the difference between bite one and bite two, where the ball fits in the socket. And that difference can be minimal. Sometimes it's a half a millimeter, it's a millimeter and a half. And when it's small enough, patients can accommodate that difference very nicely. They know it's there. You can literally push your jaw back a little bit and see how the entire jaw goes back slightly. And most people can accommodate a small difference between bite one and bite two. But if that difference becomes great, usually more than 3 millimeters, patients have a difficult time accommodating that, and the switch between bite one and bite two on a routine basis is actually one of the causes of temporomandibular joint damage. Temporomandibular joint damage causes chronic inflammation. Chronic inflammation creates all the symptoms. So the orthodontists themselves can be a big help in treating functional malocclusions. Now, their role in treating cosmetic malocclusions is great. And if you have a cosmetic malocclusion, I would suggest you see an orthodontist and get that straightened out. But is that going to help your TMD? No, it's not. If you have a significant difference between bite one and bite two, which is actually a total difference in the position of the jaw will slip back into bite two, comfortable joint position. And if the difference between bite one and bite two are significant, that also needs to be fixed, but not as the first thing to do. The first thing to do is to make the symptoms go away. And the symptoms are best treated by a device that unloads the temporomandibular joint by separating the posterior teeth according to a protocol. Again, to go over this again, there are three circumstances that damage the temporomandibular joint. Bruxism is one. Acute trauma, automobile accidents, athletic accidents, bar fights can damage the temporomandibular joint. And the third major cause is functional malocclusions. So it's the sequence that is important. It is the sequence of treatment that I want to bring out with the dentists and the public watching this, patients who have this problem, so that they understand it. It is my mission, my stated mission, to bring out correct, proper information about the diagnosis and treatment of temporomandibular joint disorder, TMD, to both the profession and the public. Excuse me. And not get sidetracked by doing things that only treat symptoms. This information, which is TMD Demystified, that is my mission, to demystify the diagnosis and treatment of TMD, actually has been out there, available for decades. The orthopedic surgeons are well familiar with the fact that chronic inflammation within a joint, knee, hip, elbow, will send signals to the brainstem announcing the chronic inflammation in the joint, and the response from the brainstem, from the lower areas of the brain, autonomic nervous system, is to send nervous signals back out to tighten the muscles that move that joint. And this has been proven, this has been elicited on peer-reviewed literature. Let me just share my screen if I can. Briefly, you can stop your video if you want to look up some of these references. But these references go back all the way back to the initial one in 1906, which talks about the general concept of joint protection through the autonomic nervous system to tighten the muscles that move that joint. And when muscles get tight, they pull on the bone, and where they pull on the bone creates pain. That is where the pain is originated from, muscles pulling on the bone. It's not tired muscles. It's actually muscles that are contracted beyond the usual and customary, which pull on the periosteum where the nociceptors are, pain receptors. So this information is out there, and this is a slide that I've used multiple times before, but I want to bring out the point today of the proper role of the orthodontist. Not to diminish your abilities or your role. In fact, I think your role is extremely important, but it is not the initial treatment that you need to do. The initial treatment is to first get the patient out of pain and other symptoms. The other set of symptoms are the non-painful symptoms: ringing, tinnitus, subjective hearing loss, fullness in the ear, dizziness, vertigo. Those three symptoms, better known as Meniere's disease, are created by the chronic inflammation going through the petrotympanic fissure into the middle ear, creating damage to the structures of the middle ear, or changes to the structures of the middle ear of hearing and the vestibular mechanism, which keeps you upright, keeps you balanced. That is the mechanism, again, created by chronic inflammation. And the easiest, best way to create is to make the chronic inflammation go away, is to unload the temporomandibular joint according to a protocol. 24/7 for 2 months, nighttime only the rest of your life. That 24/7 is limited to 2 months because longer than 2 months you can get super eruption of the posterior teeth, but not in 2 months in an adult. What you will see in an adult is the whole mandible dropping back to centric relation. And that is the problem. You have a functional malocclusion where there is a large difference between centric occlusion and centric relation. Large difference between bite 1 and bite 2. And that will need to be fixed, but not as the first stage. That would be the second stage. First, you make the symptoms go away by unloading the joint, just like a set of crutches unloads a knee, or a sling unloads the elbow if you have tennis elbow. Both verified treatment, appropriate treatments for people who have inflammation in the hip, the knee, or the elbow. Fortunately, in the oral device, you can wear it nighttime the rest of your life, and it allows the inflammation to keep limited or down, to go away. When the inflammation goes away, all the symptoms go away. That is the fact. So doing orthodontics just to straighten your centric occlusion, the first bite. You can have perfect centric occlusion, bite one, and have a significant difference between bite one and bite two. And when that significant difference gets larger than 3 millimeters or so, many people cannot accommodate that difference, and it's a constant motion of the jaw joint itself coming in and out, in and out, in and out of proper position that damages the joint, just like jogging. Jogging would do this to the knee, and if you have a difference, significant difference between bite one and bite two, you're constantly beating up this joint, which will create chronic inflammation. Chronic inflammation creates the symptoms. So first you get rid of the symptoms by using the protocol and device, and when that is done, then if they have, one of the primary causes is difference between bite one and bite two that is significant enough, then it is very appropriate then to fix that with orthodontics, braces, orthodontic treatment. And when it's significant, when that difference becomes 5 millimeters, 6 millimeters, 8 millimeters, or bigger, then the appropriate treatment is not to try to fix that with orthodontics alone, but that's when you call up your oral and maxillofacial surgeon friend and say, I have a bite problem here, I'm going to need your help. And with a combination of surgery to move the entire jaw where it belongs, and orthodontics to get the centric occlusion as close to the centric relation as possible so that there is a limited difference between those two bites. A small difference people can accommodate, a large difference they can't. And that is the real role of the orthodontist, to help or to have an oral and maxillofacial surgeon help them fix a functional malocclusion, which is different than a cosmetic malocclusion. So functional malocclusions, that is the role of the orthodontist, and sometimes with the help of an oral or maxillofacial surgeon like myself. I've done surgery on the jaws thousands of times in my 50-year career. I've worked with many, many orthodontists here in Middle Tennessee during that 50-year career, and it worked out very well. So that is what I'd like to bring to the attention of my orthodontic colleagues. I hope I have explained it in a way that if a patient views this, that they understand the difference between bites, different kinds of bites, bite one and bite two, centric occlusion, centric relation. And these have a profound effect when they're off normal, when they're abnormal, to create damage within the joint, just like damage in a knee creates chronic inflammation in the knee. And damage in the temporomandibular joint creates chronic inflammation in the temporomandibular joint. And it is the chronic inflammation that creates all the symptoms of TMD. We need to get away from just trying to treat symptoms. You can treat symptoms, but at best, it's only temporary, at best. Sometimes treating symptoms doesn't work at all. Won't name for our purposes here the things that are trying to treat symptoms. The one that comes to the top of my head is drugs. For sure, drugs is just a temporary. And Botox, by the way, botulinum toxin A, is just another drug that paralyzes muscles, but you have to get it redone. If you have a pain in one place, you can paralyze that muscle and it won't work and it won't pull on the bone. But what about all the other symptoms that you have? And what about the pain that moves around from one side to the other or from the lower to the upper? It reminds me of a patient that I saw years and years ago. She worked for a plastic surgeon and had access to all the Botox she wanted. And she came in to see me with a motionless face, and her face was shiny. It was so shiny and motionless. She had so much Botox in her face, and she still had symptoms. True statement. So, the proper role for orthodontist is to fix functional malocclusions when they arise. But a patient with TMD does not necessarily have a functional malocclusion. It is a smaller percentage. Not everyone who has temporomandibular joint disorder is a bruxer. That is a fact. Not everyone who has temporomandibular joint disorder has acute trauma. There is a pecking order where it does appear that more people have temporomandibular joint problems due to bruxism than trauma or functional malocclusion. Trauma and functional malocclusion are secondary to bruxism, causing secondary incidents. So bruxism is important, but you need to understand how the system works. And one of my degrees is in one of my experiences in facial growth and development, working as a fellow for 2 years under the auspices of the National Institute of Health, National Institute of Dental and Craniofacial Research on facial growth and development. I developed a good understanding of how the face and jaw works and functions and develops, and from that made a lot of traction on solving this problem of temporomandibular joint disease. If you'd like to comment or criticize or ask questions, I'm available at tony@tmjservices.net. If you are a dentist and would like to learn how to treat temporomandibular joint disorder, if you are an orthodontist who would like to learn how to use a device that will predictably make the symptoms diminish because you've taken away the cause, chronic inflammation within the temporomandibular joint, you can find out more about us at www.urbanictmj.com, URBANEK, urbanictmj.com. All the information, all of my blogs, which I write on Sunday night. I do a podcast on Tuesday morning. My blog, which I wrote Sunday night, is entitled, the same title that I used today, The Proper Role of Orthodontists Treating TMD. All of my 186 blog articles are on our website, which, again, my mission is to describe the facts, the truth about this problem, and not go round in circles which are not benefiting the patients with this problem. I see patients just going around in circles between doctors and physicians and various kinds of treatment that are at best temporary and at worst are not effective and on occasion are catastrophic. And some of those can be surgical and some of those can be misdiagnosis. So I've talked on that many times before, but enough for today. I hope this is valuable to you. I hope to see you back next time, which will be on a Tuesday morning. I am Tony Urbanic, and this is TMD Demystified.